first of all, nobody likes to watch their mother or father die. And even though, thankfully, my mom and that went relatively quick in that, but I could see her steadily go downhill.
My mom came to Canada about the same time I did. Kind of interesting. She lived in a senior's residence very happily for quite a long time. Then she moved into a lodge. Then her health started to deteriorate. And she was assessed as requiring long-term care. This is in the mid-1980s. There was not a long-term care bed available for her in Edmonton in the mid-1980s. She was shipped out to Gibbons.
My mom was a healthcare aide, and I was in high school. And then when I got out of high school, I started working. I had people live with me, handicapped people live with me, disabled, and I also did respite. And then I kind of got out of it for a couple of years, but I missed it. And I came back and I worked in Carmagay for 17 years as a healthcare aide.
Well, I've been involved in the seniors housing and essentially continuing care systems for a little over 35 years now. Most of my time was spent in the provincial government in looking after policy development in seniors lodges, but in the late 90s, early 2000s, I began to become involved in continuing care and especially long-term care.
Yeah, it's been hard knowing that you know, the people that the government that you put trust in had no feelings about. I mean, she was just another, I guess, a consumer of services to them. I guess, I forget the exact term that they like to, client. She was just a client.
Sometimes the lines got skewed between being mayor and being staff because I felt, this is where I get emotional, because I felt like 18 of my residents were evicted. And they had no say, and they didn't do anything wrong. And some of them were pillars of the community that suddenly had to leave because somebody made a decision that we had no influence or input on.
For the past 20 years that I've been looking at this system, it has been in steady deterioration. It is not getting better, it is getting worse.
I would say no, it hasn't exactly evolved the way I thought it would, in that I thought there would be a greater balance between home care, supportive living, and long-term care.
Is there anyone here you think might be willing to talk to us this afternoon about their experience? No.
Everybody's pretty much wants to move on, to be honest.
Yeah.
It's still very raw.
Still,
Yeah. And not so much, you know, it's not so much the closure, it's how it was done and the lack of compassion. I think it's not like, you know what, they're resilient, they can move on, we'll find a use for the building, but it's just the lack of compassion. And to know that you know, you're not worth as much as numbers on a page. I've worked in a private healthcare facility and I've worked in another public healthcare, and I've seen the difference, and just the level of care that you got in Carmagay was second to none. I think that's why I stayed for so long, was because people really had a quality of life that they were, because of the level of care that they received. We had stopped receiving patients in May, but we didn't know why. And we had 2 empty beds, which was highly unheard of because in the end, at the end, you found out that they had stopped receiving patients, but up until that point, we had overflow patients that we were receiving from Calgary because there was no other safe location for them to be, because we were a locked facility, and so we still had overflow, and then suddenly we went to empty beds, which everybody thought was very odd, but weren't sure what was going on, and then AHS came in and told us that they were closing our facility because it no longer met standards. Well, the building was built in 1959, which they kept, AHS and the media kept alluding to, but it was completely renovated in the 80s, and then there was upgrades done in the 90s. Right up to June of that year, we had new windows put in, new hot water tank, heaters put in, redone the grounds. Like, it's a new boiler, boilers were done a few years ago. Like, there was just a whole gamut of upgrades that were done to the facility, and so their reasoning behind that, it was an old decrepit building that leaked and all that, I mean, they were completely unfounded. Anybody that came in the facility couldn't believe the state of it. And even so, after the closure, AHS said that they were doing studies to check on, you know, the integrity of the building before they would turn it, because they were originally going to just turn it over to the village. But then after their first study, they realized this place is beautiful and it's in really good shape, and then it was, we can't just turn it over to the village because it's worth something. How it worked was, after they had our staff meeting, they called the families and they said, we're closing Carmigay, where would you like your dad to go? And that's how some of them were told. Actually, several of them were told that way, that we'll have to find a place. They were given no warning, no, this is what we're thinking of doing, or you need to start thinking of where you'd like them to go. It was like, we're closing, where do you want them to go? There was no. Well, the community is very close, and it was shown, and not just the village, but the whole area and the county, and it's rural Alberta. Everybody rallies together, and you know, everybody came together. As soon as word got out, it spread like wildfire, and the community, AHS wanted to set up a meeting and do all this arranging, and we said, you know what? No, it's going to be on our terms. You guys have made your decision now. It's going to be on our terms. So we planned a community hall meeting and invited them to come to it and to answer questions and to hear what they had to say. They said at the public meeting, AHS said that they never had any intent to warn the community. They never had any intent to negotiate with the community. Their intent in the AHS model is just to come in and close it. And when we look back on the paperwork for the meetings held up to the closure, it's all there in black and white that this was their intent. They were just to meet with staff. Well, actually, in the email that was leaked to me on the planning of the closure, it was a heartfelt meeting with staff. So to know that the people that were delivering the message, it was all staged, just is a huge slap in the face. But to know that that's part of their rollout plan, instead of sitting down as adults in communities and saying, this is what we're looking at, the facility in your community is not viable, we're looking at closing it, that's not even on their radar. They don't plan on engaging communities. That's not the AHS model. I'm pretty sure they didn't expect the kind of uproar that we had. We did a rally in Carmigay at the end of July, and then we went to Redford's office in Calgary, and we also went to the steps of the legislature. Our community is only 270 people, and we had, I would guess, over 300, well over 400 people at the one rally. And then we started a Facebook page to keep it open, and we had almost 2,000 people on that. Just other people saying, is our community at risk? How did you know it was coming? And so, you need to be proactive, and you need to be asking the questions, like engage us as a community. If this facility isn't viable, we want to know, you know, we want to be told. The realization is that this is going on other places in Alberta, and so people are still talking about it because it's happening everywhere. It's not just in Carmangay.
Well, like all mothers and that, she was a very loving mother, but also, you know, when we did something wrong, we knew about it. Typical 50s, 60s mother and that. Well, she took a fall, and they took her over to the hospital. And then they discovered that she had a blood clot in her lung, and that she was clotting quite a bit. They determined at that time that it wasn't safe for her to be by herself anymore, and the doctors felt more that they could give her a lot better care if she was in long-term care. So basically, she was put on a waiting list for to get into Strathmore. Strathmore is a fairly large community. It's 12,000 people. When that hospital was originally built, there was only about 3,500 people in Strathmore. So the hospital was the right size for that time. Now, for a community as large as Strathmore, the long-term care beds and that, just basically even using the kind of the government's own statistics in that, we should have had twice as many beds. So they knew that there was a necessity for more long-term care beds in Strathmore. And so every time an election, it seemed like an election would come up, they'd say, oh yeah, we're going to build it. It's in our capital budget and that. The only thing we found out later that, yeah, it may have been budgeted for, but the funds for building that facility had never been approved. Her first place actually was in a private facility up in Calgary. And she was there for about 3 months. And it was kind of a horrible little place. They didn't really take care of, it was bleak, like the paint was like brown on the walls, and the building maintenance was just horrific. Calgary was close to me, and so I thought, well, okay, we'll try it. But it turned out that I felt she was at risk in that facility, so then I moved her. A place opened up in Didsbury, and I moved her to Didsbury. So it was a good place, with the exception that it was a 2.5-hour trip in that for me to drive to Didsbury, just because of the way the roads are set up and everything. And so basically I would drive 5 miles or 5 hours in that to be able to visit with her for a couple of hours once a week in that. Well, basically, I got a call from the lady in charge of basically the long-term care center and that. And she said, we have a room that's available. It's a little bit smaller, but it's than the one that you have in Didsbury, but it's a private room. So within about 3 days, like everything was packed up and moved, and she was back in Strathmore. She was happy there. She liked all the nurses and the nursing attendants, and she felt very comfortable there. And you know, she had her own little life there. I received a letter that from Alberta Health Services saying that we're holding a meeting in that to discuss an important an important situation in that with your family and that, or regarding your family. Then so we went to the meeting, and basically they said at October October 1st, we're going to begin shutting down the long-term care center, and you're all going to be moved over, or your parents and that are all going to be moved over to Aged Care's facility, Sagewood. And basically it was more or less, this is what we're doing, and you have no real option. This is where you're going, or this is where your parents are going, and if you don't like it, well, sorry. And that's pretty much the way it felt. It was a done deal, and that, you know, our parents didn't mean anything, that they could do whatever they felt like with them, and there were no alternatives. It's either do it our way, or, well, you can take your family home. Why is it that for 10 years, the government could never ever find money to build the long-term care center over at Strathmore Hospital, where it makes sense, because people who are in long-term care and that are people who are medically at risk. But again, it goes back to like 10 years of promises that turned into, well, they finally gave the money, and that was promised for this facility at the hospital to a private operator. And that didn't sit well.
Last year, they had a capital budget allocation. I think it went to 11 providers. 9 of those were private for-profit operators, and they got the lion's share of the money coming out.
And what was that money used for?
It was used to subsidize the building of facilities. And the interesting thing is, you know, we've seen this already. They build the facilities, the private operator owns the facilities, even though public money has been used to build it. They end up pocketing the public funds that were used to subsidize the building of that facility, because they own the facility. They're free to close that facility, to sell that facility, if that makes financial sense for them. And there's no accountability for the public money that went into it. Essentially, it's an unregulated system. And that's the problem with it. Oh, in lots of facilities that are privately operated, they used to publish lists of the charges for services in addition to the accommodation charge. So if you required your medications to be tracked and administered to you, that was $200 a month. If you had to have someone take you down to the dining room, that was another monthly charge. If you required someone to help you bathing, that was another monthly charge. These things skyrocket very, very quickly. And it's not uncommon to people to be facing $5,000 or $6,000 a month in charges in those facilities. Essentially, those facilities are cherry picking. They're hoping to get people that require low levels of care. But once the care starts to deteriorate, then they pile on the extra charges. Patients who are diapered, they wear a diaper that has a little strip on the side that shows whether the diaper is full. And we have instances in which people are told, you do not change that diaper until it's full. Yeah. We had a story came to our attention a year ago when we held a press conference on it, of a lady who was at a care facility where this was the rule. And her 2 daughters took her out of that facility and looked around for the best they could find in a private facility. And they found a brand new home that has just been set up supposedly as a long-term care facility. So they talked to the lady who had this home, and she said, oh yes, we can look after your mother. It will be $3,500 a month. Oh, well, they could just about swing that. So they signed a contract. And the mother went in. She was the first patient in that home and was quite happy there. But the home gradually filled up. And then the next thing the daughters heard from the home was, well, your mother's needs are a little higher than we anticipated. And we're now going to have to charge you $5,000 a month. And they said, no, we already have signed a contract with you. You said you could look after our mother, and we've signed a contract. Well, I'm sorry, we just can't do it for that money. We could move your mom down to the basement for $4,000 a month. They said, no, we have a contract for $3,500 a month, and you said you would provide that, and we're sticking with that contract. The next thing they know is the operator has shipped their mother off to hospital with a supposed infection of the bladder, which is a condition which would normally be treated within a care facility. She was evicted by ambulance. The next day, her room was filled with someone prepared to pay $5,000 a month.
I do think that the bang for the buck is what is largely driving this. Because in my view, and I emphasize it is in my view, the continuing care system is underfunded. It's the poor cousin in the healthcare system. So if you don't adequately fund that system to provide home care, supported living, and long-term care, then you need to allocate the dollars where you can get the best bang for your buck, as you say, and that tends to be growth in home care and growth in supportive living. And the more expensive side of the system, the long-term care, gets further neglected. What we've seen over the last while is, I would say, somewhat of a deterioration of long-term care facilities as aging facilities, many of them 40, 50 years old, are now not being renovated or repaired or replaced because the capital funding is being focused on supportive living. And as I say, I think it's the right thing to have a mixture of supportive living, long-term care, and home care, so that we have the right place for people to age that can respond to their needs. But I think there's been a bit of a focus, maybe a bit heavier emphasis than there should have been on building the supportive living side. There is a lesser degree of care in a supportive living environment, which is exactly what the model called for. It said, not everybody needs a long-term care facility. And if the only option out there is a long-term care facility, then you have people who are moving to a higher level of care than they actually need, and they could probably be in a space, in a facility, a home that provides a more home-like setting. But the converse is true too. If you've aged in a supportive living facility and we haven't replaced the long-term care beds, then where do you go? And where are you going to get the level of care that you need? In some cases right now, the only place that you can get that care is in a hospital. And that's not a place to live. That's not somebody's home. You know, some studies were done about 5 years ago now that showed that in a long-term care setting, people are less likely, 3 times less likely to need to go to emergency rooms than if they were in a designated supportive living site. And things may have changed a little bit over time, but I think that we're seeing the same general trend that if people are in a setting where the appropriate care can be provided in that setting, then they can be kept out of a hospital situation. And we know that anytime somebody moves into hospital, and especially if they're admitted to hospital and they're a senior, their life expectancy is shortened. And certainly their quality of life is affected. I think government needs to recognize, and I do see some indications that they're beginning to, that the continuing care system is part of primary care. It's part of prevention. That if you can provide supports to people at the early stages of their care needs, if you can prevent people from needing to go into emergency rooms and hospital, you are actually going to save dollars overall. Or you're going to avoid having to spend more money, might be a better way of putting it, as opposed to save dollars, because we're always going to see growth in the cost of the healthcare system. We have an aging population, we have a growing population, so costs are going to rise. But in terms of percentage of GDP and so on, I think we can be more effective if we put a bit more emphasis on keeping people out of hospital. And one of the areas that can do that is an effective long-term care system. When I was with the Alberta Continuing Care Association, one thing that we continually asked from Alberta Health Services and from the government for that matter is, what's your plan? You have the figures, you have the facts, you know what the population is in the province, you have the demographic information to know where the old people are, whether people are moving or staying. You know what facilities are out there right now and how old they are and the condition of those facilities. Have a plan and make that plan public. My experience is if you talk to people and tell them what the needs are and be open with the facts, you can get some incredibly innovative ideas from people, as opposed to putting them in the position of having to fight a decision that's already been made. Get them involved in coming up with solutions.
In June, she wound up getting a lot more infections, and they were treating them like kind of one after the other. They were doing kind of the best that they could, but I think she was kind of almost like, well, I don't want to move again. And I think she kind of gave up a bit too, because it just didn't seem like she was, you know, she'd always bounce back from it, and she'd always be reasonably well afterwards and that. But this time in that, it was just like, she didn't really bounce back at all. And then it kind of got progressively worse. And then by about the middle of August, then they told me in that her kidneys were starting to fail and that she'd probably pass a short time later.
Now through that, can you tell me, were they still planning to move them?
As far as I know, yes. If she would have still been alive, you know, I was almost in the position where I was going to say, you can arrest me, you can do whatever, but my mother is desperately ill right now and there's no way that you're moving her out of this building. And I don't care if she lives until December. She's she stays right here because she needs medical attention. And, but as far as I know, they were going to move her, no matter what. It was a sad day. You know, no one ever likes to lose a parent. You just kind of assume that they're always going to be there in that, or you hope that they're always going to be there. And
where did you lay your rest?
Out at Hazar Cemetery, which is about 3-4 miles away from our family farm. And Mom was always a small town girl, and she had told me in that when she died, that's where she wanted to be, in that. Probably where we'll all go eventually.
So she's back.
Yeah.
As staff, I took a position somewhere else. But when I seen how public health is headed, I've spent 17 years here doing it, and it's just not the level of healthcare that I think Albertans deserve. And I just couldn't continue to work for Alberta Health Services. And I know I'm not the only one, that there's several that have just walked away, said, I can't do this anymore. If this is where public health is headed.
Unless you're actually in a situation where you have a parent in long-term care, you don't really understand all these things. And it's really hard to convince people in that, you know, you need to be thinking about this because you never know when your parent's going to need long-term care. And you don't want to be in a situation in that where 90% of the time is you're thinking about, or you're worrying about, well, what kind of care are they going to get?
So let's privatize
it. And that gets my blood boiling. Because sometimes I wonder if they don't set it up because they don't want it to succeed. Because as the population ages and more people need long-term care, if they don't have to, the government doesn't have to have input, doesn't have to regulate it, doesn't have to guide it. They don't have to be accountable for it because it's all in the private sector. You might get good care. I mean, there are some private facilities that offer excellent care, but there are a lot of facilities that are in it for financial gain. And I see in Carmangay that the decision was purely made by financial items. I mean, that's what it boiled down to. The staff and the patients, that it was a financial item outweighed the, you know, the common sense, the what's best for the people.
So the excellent quality of care was just too expensive in the government's eyes.
Yeah. And I think that's the model. That's my opinion, but I think that's the model for healthcare, is that, you know, if you want good quality care, you're going to have to pay for it because we're no longer funding it.
Healthcare is not a business. Healthcare is it is there to care for people and provide care for people. It needs to be run in a business-like way. It cannot be wasting dollars. The funding has to be used to provide care and get the most benefits from it. But there are going to be some situations that simply are not economical, but are needed. And I think that's probably where there's a very strong role for the public sector, the fully public sector, to be engaged.
You know, I'm one of the lucky ones. I'm 82 years old, and I'm really in remarkably good health.
I thought you were about 10 years younger.
No. No.
So
and I can still drive. But yes, the day will come. And my hope is that my passing is quick and painless, because I do not want to get caught up in the kind of care system that we have now.